Great. So Mia, if you would help me while I go through the welcome and kind of setting up our discussion. If folks are raising their hands, if you would flag for me, because I'm actually going to look at my screen for a minute for my notes. So welcome everyone to the provider reimbursement breakout. Just a little bit of reminder about what we're doing here and the intended outcome. The purpose of our discussion here is to get final input from you to inform how we approach provider reimbursement in the actuarial models. So you'll remember the pre-record that you listened to. We have some subject matter experts here, Janine and Shane, to help us with the discussion. My role as your facilitator is to try to get feedback from everyone who wants to contribute, which might mean that I bring the conversation back to the topic if we veer off, which is entirely possible and understandable. So for this discussion, we're hoping to understand your overall philosophy around provider reimbursement. Our questions are aimed at understanding what you think is the right balance between controlling system-wide costs, compensating providers, and ensuring access to needed care. There's limited research on provider payment in Washington State, but some general themes exist on provider reimbursement, including that reimbursement varies by type of insurance payer. Commercial health plans pay providers more than public plans, such as Medicaid and Medicare. In general, reimbursement favors specialists over generalists and primary care providers. Certified but unlicensed providers are poorly paid. And on average, women and BIPOC providers are compensated less than white male providers, likely attributed to a lack of transparency about pay equity within healthcare organizations or because of the different settings in which an individual provider practices. So our questions for discussion, I'm going to go over both of these questions and then we'll see if we want to go one by one, or if it starts to get just kind of more generalized to the questions. So number one, for universal coverage options, should the model assume lower administrative costs for providers due to a simplified system, and why? And the question number two, should modeling of the universal coverage options assume that the state will have greater purchasing power that will allow the state to modify provider compensation as proposed in similar studies? Okay, so I'm going to pause there and ask if you all have questions, if Shane and Janine want to weigh in at this point, and then we can jump in.
This is Shane, and I think it would be helpful to go one at a time, and if it's all right, I'd like to provide a little bit of context around what we see in terms of research and data to inform the discussion. If we were to start with the first question of do we want to go ahead and assume that some of the provider side efficiencies are captured in terms of reduced cost in the model? I'd actually start pretty high level in terms of the reason we ask this is that it's quite impactful, that even a 1% change in reimbursement can translate into literally hundreds of millions of dollars when you're talking about the scope of a single payer system. It obviously looks quite a bit different to one of the other models we're looking at, which is the close the gap model. But this is a pretty important question for the universal healthcare model, single payer. In terms of evidence, there have been, as was actually mentioned in the precursor to the breakout, multiple different studies that look at what happens in terms of relative levels of administrative efficiency under different models. So for example, there have been studies that compare provider administrative cost in Ontario, Canada to typical rates of administrative cost in the US. And they find really significant differences, in some cases as much as a 400% order of magnitude difference in administrative burden across systems. But looking at the evidence within those studies, you see that the things that drive that are not necessarily the streamlining of the the systems and reducing the interaction with multiple payers, but predominantly some of those more operational decisions, such as the level of prior authorization requirement burden that's placed on providers. And that doesn't really, we won't get down to that level within our conversation. So because we recognize that there is a strong push for, looking at these models robustly and what can be accomplished, we think it's important to ask this question of, should we capture those administrative savings that are experienced by providers? But we recognize that the evidence base doesn't necessarily provide us a really discrete, quantifiable amount for that. So we're really looking for what insight you have into the delivery system and practice operations within your state that could help us better interpret what evidence is available and see how applicable it is.
Great, Shane, thank you for teeing that up. Let's pause there then, in keeping with Shane's recommendation that we go one by one, and I'll invite thoughts from our work group members.
I see Aaron has his hand raised. I'll unmute him.
So that's what you want us to do, is raise hands. Okay. So I appreciate that, Shane. I would just say, from my reading of studies, comparative studies, which actually, I have not gone to the depth that you were just describing at the end, which is, well, there are differences, but what are the reasons for the differences? But every study I've looked at, including one I did comparing administrative spending in British Columbia and Washington State, it's now almost 40 years old, but shows, as you noted, at least an order of magnitude, if not more, difference. Now, it may be that there are some sort of granular differences, but I think it's hard because if you look across, if you look at comparative studies that involve Germany, thinking the ones that I'm aware of, the Netherlands, Canada, maybe the UK as well. I mean, it's pretty consistent that the amount of administrative spending overall, and particularly in provider offices, that is, the difference is very significant. So I think, to me, the answer to your question, or this question about whether we should assume that, a lower administrative burden, capturing the savings, I guess is what the term that you use. I think the answer is yes. How much? We could dicker about that, but I think it's very clear that a single payer system will have a lower administrative burden on providers, and as a result, that component of provider fees will be lower.
Can I ask one follow-up question? I feel like you have some great insight on this. And I think this is a challenge that we're running into quite frequently, which is, the key to using evidence appropriately is to ensure that the situation that you're applying it to is significantly similar, such that the results can be extrapolated appropriately. And I think the fear this creates in me is that we build a model that predicts a certain level of costs and is predicated on assumptions about how downstream decisions about design will be made that we just really have no insight to, and it could actually have really dire consequences for the state of Washington. And we take that incredibly seriously, and not just as a matter of reputation, but a matter of respect for what you're trying to accomplish. And so I'm wondering if the way that we navigate this challenge is that when we do make these assumptions, that we're identifying some of the criteria that were necessary to make them true, and that the work group actually affirms those as positions within the final recommendation report, that this is our guidance. You need to adhere to these principles. And it may be something as go easy on PARS, because those do seem to be something that contributes pretty significantly to administrative burden, without respect to the number of providers that are there, because the total volume won't be changing. Do you have thoughts on that strategy?
That sounds like a very appropriate strategy, Shane, to me. That is, here's sort of our policy position, if you will, which leads to this level of savings. But here are the stipulations, the things that that the system would have to adhere to in order for that to be supported I think that's totally appropriate.
Thank you.
In my view.
I see Dr. Tritko. I'll unmute you.
I'm unmuted. Well, first of all, I would disagree with the notion that single payer somehow reduces administrative costs. I don't think anything can be further from the truth. Dealing with Medicaid healthy options, dealing with Medicare Part C plans are by far the most burdensome plans that are out there. I would rather deal, and I've been doing this for 30 years, with Primera regions any day of the week because they don't hassle me. They don't provide barriers to my patients getting care. I think the problem that we're making is that we're asking the wrong question. What we're looking at provider reimbursement is, first of all, is to reduce cost of inflation, which has been a huge problem, particularly on the hospital side. We need to reduce cost variation. As we saw from the Milliman report in February last year, hospitals charge between 200% and 350% of Medicare. Why is there that great variation? And then from the physician side, the most cost-effective mechanism that we could take and that we should be working on immediately, we have a way of doing this, is to eliminate care that is very low valued or negative value. We need to get rid of the wasteful care that we're administering. We need to eliminate the cost variation, and we need to eliminate the cost inflation rather than changing how we pay people. Because how we pay people right now is the Medicare fee schedule, Medicare rules. Pretty much everybody's done that for the last 10, 15 years. But the way that is implemented with various barriers is what causes our administrative burden.
Sue, did you want to go ahead?
I just want to build up both of the comments that have been made. And I do think that here in Washington, building on the very large repository of evidence-based work with the BRE and Health Technology Commission are going to be really foundational going forward. I would also think that it's going to be critically important to begin an evidence-based social health policy center or social policy center, because I think we quite simply will reduce a lot of the over-medicalization in the system to create some of these efficiencies that both of our speakers talked about. We have to absolutely get to reducing the over-engineering of rules, and we can do that by really enhancing IT. And I don't mean meaningful use EHR stuff, but really getting to intelligent data and really driving towards some of those outcomes. I also think that basing this work on very clear total cost of care work so that we can have parity throughout the system is going to be critically important. And I can't understate enough the community social part of this work, because as with the COVID epidemic, we have so over medicalized and concentrated on parts of the healthcare continuum and not taking care of all the downstream providers that quite simply have needed masks and other basic things. And so we've got to level out in the entire system more of this partnership with our social and community-based organizations. So just want to throw those things in because they will drive towards a better administrative spend. And in my opinion, we have to really drive efficiencies all across the system. Thank you.
Thanks, Sue. Pam, did you have some comments?
Am I unmuted?
Yes.
I agree actually both with Aaron and the good doctor, even though it sounded like they were disagreeing vehemently. Every single payer system administrative costs are dramatically lower than our administrative costs. It's just an empirical fact. But then when we try to introduce savings into our systems by lowering administrative costs through Medicaid and Medicare government programs, I think the doctor's right. I mean, it just drives you crazy. There's a huge amount of regulation and a lot of it with very limited value. Part of the problem is we have people balkanized into all these different programs with different regulations, different eligibility requirements. We spend a lot of time policing, are the right people in the right program? Are we doing the right things for them? And we have layered so much complexity into our system, and then it costs too much. And then we go back and try to save money. Those things add additional layers. So we're kind of, I mean, I understand why people who are in medical professions are going crazy, because we never take a regulation away. We just keep layering more things on top of it. And yet I don't really, you know, you can't help but admire what happens in Canada and in France and the Netherlands, but I don't see a path to get there. So some of it is, you know, facing up, because some of the things that Sue said is kind of having to face up the system we have, and how do we peel off some of the administrative burden in the system that we have without losing ground in terms of cost control. We're in kind of a complete Gordian knot on these issues.
So I'm going to, as the facilitator, take a pause here. We have less than 5 minutes, and I want to make sure that Shane, you get what you need in terms of the second question. So do you want to tee that up, and we can invite some comments, some thoughts? You're on mute.
Thank you.
Mm-hmm.
I'm trying to think of a simpler version here.
I know it's a complicated question.
They are. Unambiguously, an increase in purchasing power could create additional leverage. That could impact a lot of different areas, from high-cost drugs to dealing with hospital systems that may have monopolies. Just the dynamics look very different. But it will take a certain political fortitude and an understanding of dynamics at a more granular level than we have to understand where that opportunity really is. And this is less evidence-based and more us needing to get some insight in terms of the delivery system and where there are greater opportunities. We did receive the Milliman report. That was quite helpful in terms of understanding where there's variation, but the strategies by which you act on that variation matter a ton. I think we'll probably have to continue this conversation, and Kelly, thank you for your comment. I appreciate that. But broadly speaking, do you have insight in terms of areas where we think, like for example, primary care is underfunded in certain areas, therefore we should, in our model, assuming greater financing, or conversely, so we recognize that we're overpaying for pharmaceuticals, we're overpaying for hospitals. Based off of your experience, where would you recommend we focus our efforts for modeling?
Kirsten, I know you had your hand raised. Did you want to respond to that?
Well, I guess I just have an overall comment that I think we also need to bring the quality of care and access to care into this discussion, because savings is not going to mean a lot to people unless they feel like they get good quality care and they have access to care. And that's something that I feel I often hear in the debate, the fear people have of universal health care options, that somehow their quality of care and access to care will be compromised because of being under that type of a plan coverage. They've already experienced Medicare and Medicaid clients that there are a lot of offices that just will not accept them as patients or new patients. So I think that's important to keep in mind during the discussion as well.
Yeah, we're struggling with the time constraints here. So appreciate the comments here in the chat about not having enough time, which seems to be a theme for today. Absolutely.
Yeah, I know we're just about at time. Rod, did you have anything you'd like to add?
Yeah, I would just point out the Milliman study shows that hospital costs are 200 to 350%. You have to realize Medicare hospital payments have almost doubled over the last 10 years, whereas the physician conversion factor into Medicare next year will be roughly where it was in 1991. I agree that we need to emphasize primary care and prevention. We need to eliminate low value, expensive care that occurs in hospitals. That doesn't occur by paying primary care more. That occurs by paying primary care adequately and reducing any barrier to getting to see your primary care doctor.
And we might have time for Richard. I'm not sure.
Thanks. Just to add a little bit to this, I agree with Rod just said about paying primary care appropriately. There is a parallel track that's going on now to try and raise our 5% extremely low primary care expenditure to 10%. Actuarially trying to put some teeth into what that might do in terms of the savings. There is a big effort to give you dollars and cents to that going on right now. We have to reduce the administrative costs. And the one piece I would add is, as a provider in the trench, I see a whole lot of recommendations about how to provide better care. I'd use the model of the Choosing Wisely campaign, where you're not supposed to do this test or that test until this amount of time passes, et cetera. And it's focused on different specialties, but we need to put teeth in it. I mean, it needs to be enforced so we don't do inappropriate care at the wrong time in the wrong place. And then it just should be totally inexcusable to have the kind of cost variations in the system. And that is a political decision that needs to be taken to confront the forces that make that happen. But we're not going to get anywhere to eliminate, to reduce costs, because we absolutely have to start with reducing costs. And actuarially, I think we need to start, I appreciate the way you started that, Shane, with the cross-border description of Ontario and where the savings may be, but we need to really see the menu of what one can do that's not based on idealism or gestalt, but it's what we can do and how much savings would be potentially involved with each of those kind of interventions, which will all take political courage.
Thank you, everyone. Shane, Janine and I have to leave for the main room. You'll be visited by new people shortly.
Thank you, everyone.
Thank you.
And if you have your hand raised still and you aren't waiting to talk, I think you could press it again to unraise your hand.
Hello.
Hi there.
Jamie.
Hi, nice to see all of you. All right, we get to talk about cost sharing, and judging by my last conversation with folks, I think we've got a lot to talk about, so we better get to it right away. So I'm gonna kind of shorten up my preamble here. Our purpose here is to get your philosophy on cost sharing, which means we're not asking you to tell us specific income thresholds that we should use in the actuarial model. What we're really looking for is your, based on the pre-recordings that you watched and your professional and lived experiences, your perspective on whether we should consider cost sharing because you see some potential benefits to reducing unnecessary or low value care, or if we should not use cost sharing because you're concerned about the impacts on people's usage of the healthcare system. And if you do support the idea of considering cost sharing, are there specific parameters we should consider? And I see, let's put that first question about whether or not you think we should add cost sharing to the model. Really quick, Pam, before I call on you, I do want to mention that my understanding from our actuaries is that regardless of whether we put cost sharing in the model or not, the very lowest income folks, oh, Shane, you're being told to leave the breakout room and return to the main room. So, bye, Shane.
Hey.
Okay. The very lowest income folks would be shielded from any cost sharing in order to comply with federal regulations. So let's start with that first question of what your feelings are about cost sharing being included in the model and why. And we will start with Pam.
And wait, before you do that, can we just remind people that for the model, we have been talking about no premiums?
Oh, yes, I'm sorry, thank you, yes. We've already incorporated the assumption that the model would not include premiums. This was based on your feedback from the June meeting, which is your intent. What we heard from you is that you would like to see true universal healthcare where everyone participates. And so that would preclude having a premium. So, all right, let's start with Pam.
Okay, I actually didn't mean to put my hand up, but I love to talk about cost sharing, so I'm going to jump in anyway. We have learned a huge amount of this in the exchange, and I've worked on it for years. And I actually do believe in some cost sharing. I think that it works best when it's a flat rate so that people can understand what it is. I think people are completely confused by deductibles and coinsurance and the anxiety of not having any idea what their care is going to cost. At Group Health back in the day and looking at other cost sharing models, people seem to respond well to knowing a primary care visit is going to cost $25. A specialty care visit is going to cost $35 or $45. It's going to cost a little more to go to the specialist. If I buy drugs, it costs this. My blood pressure medicine isn't going to cost me anything, so I'm encouraged to take it. I think those kinds of cost sharing are effective, and I think they have a modest impact on inappropriate utilization without making people not go to the doctor when they need to go. We have a lot of evidence from the exchange where cost sharing for people who don't have a lot of assistance is very high, that they defer needed care, and that's a problem.
Okay, Pam, so I hear that you're in favor of some modest cost sharing because of its potential impacts on.
Modest, but also looking at models in which it's understandable to the consumer.
So very transparent, and that's actually consistent with what we heard in our first group. Dr. McGough, you were next. Let me see if I can. There you go.
Can you hear me?
Yes, I can. Thank you.
Great. Well, I agree that we should, have a modest cost sharing, and part of it is we really want to identify what the key goals for the health system is. That for I'll just say high value services that we want to really encourage people to utilize. That would be zero in terms of the cost sharing. On the other hand, for some other services, and I'll just pick on elective surgery. We can benchmark what the cost of a hip replacement would be and basically set this is how much we'll pay. But if you've got an orthopedist you want to see that charges a couple thousand more, that's going to be on you. And it's really incentivizing seeing cost-effective providers that are doing a good job in charging reasonable rates. So using it both, using it strategically and not put any barriers to care.
My apologies, Aaron.
So first I want to say that I guess I missed the decision not to have premiums. Premiums are not incompatible with universal systems. So for example, people in British Columbia pay premiums. And I'd actually be more comfortable with premiums than I am with most cost sharing structures. I think the burden is on those who think cost sharing, that is point of service cost sharing, are useful to come up with the evidence that they are. I think the evidence that they are barriers to care is much stronger. And I just use the example of what did we do with during COVID? We waived cost sharing for COVID-related testing and treatment. Why did we do that? Because cost sharing is a barrier to necessary care. So I appreciate my friend Pete's notion about being able, consumers being able to judge cost-effective providers versus those who are not. But I don't actually think that's the real world of patients. That most patients have no ability to do that. We don't have very good data to support that kind of decision making. So I'm not necessarily against all cost sharing, but I think the burden is on the proponents of cost sharing to come up with a scheme that clearly does no harm.
May I ask a quick follow-up question, Aaron? What made you say that you are more comfortable with premiums than other types of cost sharing?
Well, premiums, we're going to finance, we finance a system out of our pockets one way or another. Premiums is just one way of getting money out of our pockets. Taxes are another. I don't have anything, necessarily against premiums per se. I would want them to be income related, but, you call them premiums, you call them taxes, it's money out of our pocket to support a system.
I see your point. Okay, thank you. I think Kelly is.
Yes, I want to let you know that I am concerned that cost sharing as a consumer of healthcare, as my role on this committee to talk about that, I'm concerned that it puts a burden on patients to decide whether medical care is urgent and necessary. And I can give a very personal example of this. One time I was away from home and my husband called me and said, I'm hurt, I need to go to the hospital. It turned out that a splinter this big had kicked back from the saw and gone through his leg. And I said, okay, well, and he's like, in fact, I'm on my way to the hospital now. I hung up the phone with him. And then I thought, wait a minute, which hospital? We just changed our exchange plan and we had a different hospital that we could go to and be guaranteed a payment. And so I called him back and he said, well, we just pulled into Swedish. And I was like, oh no, we can't go to Swedish. You got to turn around. You got to go to North Seattle Hospital up here. And I went dashing off to the ER to meet him there. And it turned out like he could have bled out from this. He was that close to a vein. I had no idea. We're sitting there trying to make these decisions. Like, well, he's an under communicator for one thing. So I didn't realize, like, I mean, he didn't say there's a, something poking out the back of my leg. So I had no idea. And I'm very concerned. I don't know that if all the doctors realize, like, we don't have the information we need to decide whether something's really urgent or important and all of that. Like, sometimes you just need to go to the doctor and not use the web, not use what you hear from your aunt or whatever. You just need the professional help to determine whether you really have a problem or not.
Okay. So I'm hearing from a couple of you that you're concerned about the impacts of cost sharing and seeking necessary care. Let's see, Dr. Kovar, you are next up. Oh.
Yeah, I mean, I actually do support a small nominal standardized, no difference between plans type of a copay. So people at least think twice about where they're going. It should never break the bank. At the point I want, and I do think that I kind of am a bit swayed by Aaron's argument, but I think we either need to do this with premiums or taxes, but not both, because this still has to be sold politically. And I think there's a big difference to be made there. And then the only other thing just to focus on is the out-of-pocket maximums. We have to keep in mind the threat and fear of medical bankruptcy. So this has to be structured at a percentage of income or whatever that is, so that, again, for human rights perspective, but also for political expediency, there has to be a non-frightening out-of-pocket maximum that goes with any plan that goes forward.
So what I'm hearing, and again, this is consistent with what I heard from the last group, so you'll hear this when we do the sum up, is that for those of you who do see some potential benefit to cost sharing, it would still be very important that it's both transparent and so the consumer knows what the cost sharing will be up front, and also that it is set at a level so that it does not put a family or a household or
You dropped out.
financial risk. Justin, you're next.
Yes, and I just wanted to add to the consumer advocate's comment there that that's something that should probably be looked at with, sorry, I got my mask on here. Because we're looking at network access and network restrictions in combination with that. So I think that's something we need to keep in mind, and also benefit structure when we're talking about these type of issues, and setting cost, what is going to be included in that plan. But I'm with the team that does support some kind of premium and cost share. I think it holds people more accountable, and it puts value on things in people's mind. And also it gives some requirement of accountability for both parties.
Thank you, Shaston. And that was a very good point you made, that Kelly's story also speaks to some policy issues that we'll need to consider. And that's the discussion we're going to be having later today. So not just how we do the cost sharing, but also how people access providers, especially in emergencies. All right, next up, looks like in my order here, Lynette.
Great. Yes, I just wanted to support Kelly, what she was saying. I'm a nurse and I spent 18 years in home care. And it was really shameful that there's so many of my clients would only take a half a pill or maybe every other day take a pill because they just couldn't pay for it. Other times, depending on the situation, saying you really need to go in and see the physician. We are done here. We can't do any more for you. And you need, I can't, nope, I can't do that, Lynette. I can't pay for that. And so I do support having some skin in the game. I support having, you have to pay something. Yes, there's an investment. But with that, there's going to be a real balance. We don't have the answer today, but I think maybe premium, yeah, sure. Little copay, perhaps, but again, nothing that would prohibit the patient from getting care. Thank you.
Okay, so again, the parameters I'm hearing if we consider cost sharing in the model, and I want to acknowledge that there are several people on this screen here who it sounds like are not comfortable with any kind of cost sharing because of the potential impacts it could have on accessing care. But for those of you, cost sharing might be something you would consider because of some of its benefits, that the parameters about transparency and about making sure that it discourage needed care and that it does not put a family at risk. Let's see. Dr. Tricko, did you have your hand up? It looks like you might have taken it down. Are you good? You're bad? You're against cost sharing? Okay, let's see. Dr. Kovar.
I was impressed by in the video how quickly any cost sharing was dismissed for low-income people. And actually, I support that it shouldn't be a financial burden and financial cost sharing, but there are other ways of doing that, and just dismiss that potential gold mine shouldn't be done out of hand. And I use more of the example of the inappropriate place that people may get care. There are many places where there's an urgent care next to an emergency room, and the EMTALA laws prohibit the person from going right and getting the CAT scan before they're even examined, as opposed to the less expensive cost of care. This ties into beefing up primary care, and when there's appropriate access in network, then we make inappropriate ER utilization more difficult. And it's not that you just say you can't come here. There's a triage at the front door that sends somebody to a less expensive care. I think that there's enormous savings there, and we should not just dismiss it.
Jared, are you processing? Is there anything you want to pipe in on here?
Also, there's 5 minutes left. I just wanted to give everyone a heads up.
Yeah, thank you.
Yeah, no, I mean, this has been helpful. I mean, it provides a lot more than we were able to obtain in terms of our discussion last time. So that it has been helpful to at least craft something that I think either provides some options or some impacts associated with what we've heard today. So it has been beneficial. I do think, as has been pointed out by many of the work group members, some of this is policy related and not so much just simply how you set up the financing of the system. And price transparency, availability of providers, all of that stuff goes into it. So it's not just an isolated thing.
I think we'll make some notes too, so that when we're planning future discussions, we can tackle some of these policy issues. Aaron.
Yeah, I want to make a couple of comments. One is there is one kind of, or one structure of cost sharing that actually Pete alluded to. CalPERS developed a number of, that's the California Public Employees Plan, developed a program to steer patients to certain hospitals for, I can't remember what it was for, probably hips and knees. And so this is sort of along the lines, Pete, what you were alluding to, which providers they have good measurements for effectiveness and efficiency, and cost sharing for the patients was what drove patients to the more efficient, more effective providers. That kind of system I could certainly support. But the other thing, other comment I want to make is I appreciate, most of the people on this screen, I'm sort of in cahoots with philosophically and politically on a whole variety of things. But when we throw out things like skin in the game, accountability, et cetera, stuff like that, what I want to see the evidence that that's what point of service cost sharing does. I think that evidence is sorely lacking and is overwhelmed by the evidence that point of service cost sharing is a barrier to needed care. So I would challenge us all to, to not rely on what, I think are interesting and useful values and philosophies. This is why I want to focus on the evidence. What does the evidence say? Does the evidence say that co-payments promote accountability? I'd like to see that research. I've never seen it.
So let's make a note of that too, because that's an important theme that Aaron raised about whether there's evidence on this. We have less than 2 minutes left and 3 hands up. So Shaston?
Yes, I think that's a good point that Aaron brings up there. And I can only go with my own experience growing up in a nation with socialized medicine that quality of care and accountability can be an issue when too many things are for free and nobody really is responsible for outcomes of care. So socialized medicine is not always a good thing. But I also wanted to bring up my other point. Boy, now I forgot about it, so I should have skipped that. I got waited too long, so I'm sure it'll be brought up by someone else.
I'm going to take Dr. Tritko, and then if there's time, we'll grab Kelly's last comment. Dr. Tritko?
I just want to add to what Aaron said, and that I agree, but I think we do need to create barriers to low value care, negative value care, and low quality care. And to put barriers there, like you say, I mean, the low volume hip place versus a high volume, yeah, we want them to go the high volume. But by the same token, somebody that's going to get some care that is extremely low value, the total hip and the 95-year-old with Parkinson's, I mean, yeah, barrier there is probably appropriate.
Thank you. And last but not least, we have Kelly.
Yeah, I just wanted to say that one of my colleagues tells the story of at one point Medicaid was asking for a $1 copay for some service. And at that point, then the cost of just trying to administer the copay, to collect it, to bill for it, to whatever happens with that, is more than the copay itself. So you're kind of wondering, what are we doing then? And so that's another trade-off that needs to be considered.
So you're raising the administrative burden when you have cost sharing introduced. Yeah. Okay. All right. So good news is there is consistency across both the groups, although Aaron raised the issue with premiums that did not come under the other group. We're about to close out and move to the next room, but Jared, are there any last, in our 50 seconds together, any last questions that we need to ask this group to answer? Or do you feel like you have fairly clear direction?
I think we have enough to kind of take back and come back with some frameworks. I think ultimately the frameworks will be discussed in the next work group, or at least presented with some of the impacts, et cetera. So thank you.
So to Sue's original welcome, we recognize that for most issues, we're not going to get agreement from all of you, or you say go forth. There's going to be conflicting opinions, but I think what we did get was some consistency across this group about either no cost sharing and why, or if there's cost sharing, these are the parameters we'd like to see. So I appreciate your time. I think everyone now can click to go back to the main room, and we'll do a report out. So thanks for your time.
Great. Hi, everyone. Do we have everybody, Mia?
This is a smaller group.
It's interesting because I've got Nora, and I didn't think I was going to have Nora. I thought I'd have Janine. Glad to have Nora, but
I think, well, we should have, I think we can go ahead, and the recording is already gone, so.
Okay, great. So this is the discussion that we teed up at the outset of the meeting about the qualitative criteria for inclusion in any model that we choose. And for the purposes of this discussion, we want to begin taking the criteria you developed at the February work meeting, so a while ago, which articulate the priorities such as access, equity, and quality, and assessing which, if any of the three models, are capable of delivering these priorities. So the conversation that we had earlier about really needing data to, what the evidence demonstrates to be able to have this conversation, the idea for us here today is to put your, experiential hat on and weigh in. We really want to hear from you as individual work group members about what you value in terms of priorities as the legislature is, and implementers are starting to think about how to build the model. So we'll look at the three different models, and at the higher level of the criteria, the 6 categories, we'll talk about what is important to include. And if we need to go deeper and get some data, we'll speak to that. And then in subsequent meetings, in the September meeting, we'll continue with this conversation. So it's important to note here that actual implementation of a universal healthcare model will require a level of specificity and expertise that's beyond the scope of this work group. And so, what we want to do is just make sure that we're capturing your thoughts and incorporating your feedback as we move forward into the next conversation that we have in September. Janine, do you want to add anything about this before we begin?
Janine, I think you're muted.
I think you're muted, yeah.
My own phone. Yes, I think. Can you hear me now?
Yep.
Okay. It's that this is your first chance to really look at these as we have compiled them from those previous discussions. And it's really thinking about them from the terms of, does this model facilitate something, whatever the optimal best way it is to achieve access, does this model versus that model really help facilitate it more or less, or not maybe at all? So it's really thinking about the model and then what you want to accomplish. It's not going down into the details of what best access is or best quality is. It's more like thinking about the structure of the model. How do these various areas are facilitated or promoted or not? Or is it all just an ongoing implementation aspect later, that you will put into your recommendations of, well, we really think that access is super important for all, and you would add some additional depth to the actual concept. But it's really, today's discussion is think about those models, those 3 models, and how does this meet up with it?
So the plan here is to go through each of the 6 criteria in turn and think about which of the models best supports each criterion and why. So again, we want your perspectives here, your individual experiences informing this conversation. So, and that's okay. As work group members, that was intentional. So, so I think, Mia, are we projecting something at this point?
I don't think go ahead.
I can share my screen if you want to see the criteria.
Yeah, I think so, Janine. Yeah.
Yeah. Okay, just a second. It makes you all little tiny pictures off to the side. Oops, are you seeing anything about a sunset picture or?
Yep, that's good. That's very helpful.
Okay.
So we've got notes now, Janine. You shared it and then it went away.
Oh, okay.
Your notes are
All right.
helpful, but there we go.
Okay.
Yes. Okay, so for the first criterion, which is access, and you'll see what the issues included therein are based on your February input. So now the exercise is to speak to this access element and talk about which of the three options, if there is one, would best ensure access given these indicators of access.
Aaron, I see.
Aaron's hand up.
I think this is a little bit like Jeopardy, who gets their hand up first or something. Yeah, so as far as these bullets are concerned under access, I would just say most of them, my response is it depends. Now, in other words, it's not inherent in the model as to whether, for example, access to culturally attuned care is assured. It depends. I mean, you could have a colonial single payer system just as well as you could have a colonial multi-payer system or a colonial mess. So the ones that I think the model might push the scale in one direction or another is that, for example, is portability, which is a component of the first bullet. So in single payer, portability between systems or plans or benefit package isn't an issue, right? So it seems like that one leans a little bit more towards the single payer model, and maybe the option B. Choice of provider, likewise, theoretically, single payer system provides broader choice of provider, but that depends on a lot of things.
So Aaron, can I dig a little bit on that one? I think you're getting to where we really wanted to go, which was that it depends. When you're thinking about, so it depends on, if you think about implementation then, which is where we will go as we, explore more, what's the it depends for you?
Well, I mean, it depends on a lot of things, but in terms of choice of provider, for example, it depends on how well resourced, for example, rural or marginalized communities, or the health systems that support those communities. So you could have a single payer system that provides nothing for small rural hospitals and they go away. So their choice is reduced to zero for those communities. So it depends on how resources are allocated within such a system.
That's beautiful. That's exactly what, so for access, if we can stay with this theme rather than the individual bullets, if we were to have a value of access, or access is one of the principles for whatever system is implemented, what needs to be assured? And what you just talked about, rural communities being resourced, is one of those really critical elements. So I didn't mean to cut you off, Aaron, but I think this thread is important.
Okay, well, it's hard to talk about the broad criteria of access without referring to the bullets, because the bullets actually, sort of provide flesh and bone to the the criteria. So so just as another example, promotes preventive care and utilization of primary care. Well, that depends on policy decisions that we were talking about in the first breakouts about, for example, payment levels for these services and whether they're adequate to assure access to them. So I don't know. I mean, I could go on and on, but yeah, I would say choice, portability, are probably the two aspects of access that I think move the needle more towards the Model A than the other models. The other ones depend on decisions about resource allocation, depend on decisions about, for example, like, you know, culturally attuned care, whether that's a priority, you know, and whether it's included in a benefit package. So.
Thank you.
Yeah, and relates to the policies that are set on your implementation. What about the others of you? What do you guys think of what Erin is suggesting?
Rod, do you want to go ahead?
Sure. I agree with Erin. I think this is a very complicated and difficult question to answer. I think, as we saw in the RAND study from Oregon, that there's no question that as you have more government involvement, access gets better, particularly for low and middle income people. My assumption is that access is not just to coverage, which in the exchange means very little because of the limited networks and the high deductibles and copays, but actual access to care, and hopefully care that's affordable. So I think that option A would probably, on a broad scheme, have greater access than B, which would be better than C. That's one of the values of having more government involvement, that you tend to have better access, particularly for low and middle income people.
That's great. Yeah, thank you. We have a couple more hands. I just want to say that we have 6 criteria, and I don't know how much more time we have, Mia, but let's go to the hands.
Yeah, I see Kirsten. Do you want to go ahead?
Sure. I just wanted to say that I think it's been summarized really well, but I just wanted to second that it almost seems like they're lined up accordingly, A, B, C for me, how well this could be accommodated. And again, of course, it's going to depend also on like the resources, benefits, you know, structure of the benefits and reimbursement mechanism and resources that are allocated to whatever the plan options will be. So to me, it'll be very much policy driven, how well either one of this will work. But I think option C is worst case scenario for me, for sure.
Thanks, Kristen.
Great, thank you.
Peter?
So Betsy, do you move on to the governance section?
Peter, do you want to say something about access before we go? Yeah, and then we'll.
Yeah, thanks. You know, a lot of the discussions I think we've had been assuming that our healthcare system is going to be just the way it is forever. That all care is going to be in person, in an office, et cetera, et cetera. And I think one of the things that really determines access are some of the innovations like telehealth, which really was languishing, at least in most of the health system until COVID. And now it has really become a dominant mode of care and really expanding access, but also being able to have virtual chat, patients accessing their own information. So really incentivizing, provider groups to come up with different ways of having patient-centered access to information and services that don't require them going into an office and sitting down in a waiting room.
Thank you. Okay, let's move on. That was a great comment. To governance. So with these, in keeping with Erin's comment that the bullets matter, of course they do. Look at the governance bullets, and then let's have the same conversation, A, B, C.
Erin, did you have more to say on this one?
Oh, yeah.
Great.
Erin hits the buzzer.
Yeah, I get the buzzer. So just in general, what I would say is that actually I would say Model A has the potential for the greatest level of accountability, just because, from my point of view, it's if you know, if Sue Birch is running the system, I know who to point my finger at if something's going wrong, if my services aren't, you know, provided, et cetera. You know, I juxtapose that to the current system when, you know, something goes wrong with my insurance plan. You know, I don't know who's on the Regents board, you know, or the Primera board. I can't get at them. Where I can theoretically, I'll get, you know, I know where Sue Bird sits. In fact, as I can see her right there. So, and I would say, you know, model B is sort of a hybrid in that accountability is diffused through the health plans that are, you know, under contract with the state. So just in general, I would say, you know, A, B, and C are in that order of levels of accountability. The rest of these specific things, for example, tribal sovereignty, again, I mean, that could be acknowledged and supported in any of these systems, well or poorly. So I think it depends. And yeah, so.
And is it depends again is about implementation questions and policy?
Well, it's about policy and then implementation. Yeah. Exactly. It's about, you know, is this a priority?
Yep.
And the last bullet, is the patient voice a priority? And if so, how is that manifested in the structure of the system?
Other thoughts?
Rod, would you like to go ahead?
To me, this is one of the most difficult ones to understand. I think healthcare worked really well until the late 90s when it was local. When all of our providers started becoming regional and national, that's when we stopped having a say in how the healthcare is provided. And the reason is that in Spokane, these big regional and national people, they want to take money out of our community, send it somewhere else. So the profit motive becomes way too strong. That's the problem with governance. To say that it's going to do better having it solely at the state level, I'm not sure that's necessarily true. I mean, are we better off during this current pandemic with Donald Trump running the response, or would we have been better having local governments do it? So I think the best way to have governance is for there to be local control rather than state control, but I'm just not sure how we do that in a state administered system.
Kirsten?
Yeah, I agree with the last comment because that's my concern too. Sure, you can be upset about something, but if you only have the one place where your healthcare is being offered, then there are no alternatives. So that's one of the caveats, I think, sometimes with that universal healthcare coverage, at least with several options. You can go elsewhere if you don't like what you're being offered. So just something to keep in mind. Again, I think it will be very much policy driven and how the setup is and, you know, what are your recourses going to be if you're unhappy about something.
Thank you. I'd like to move us to quality and equity. And Mia, can we do a time check?
I think we have about 15 minutes.
Oh, good. Okay, so we're doing all right.
Yeah.
So in terms of the bullets under quality and equity, what are your feelings about option A versus B versus C?
Erin, I see your hand is up. I don't know if it's left over, but I'll unmute you in case.
It was leftover, but I would just, you know, I think this almost entirely depends. It depends on policy choices. It depends on implementation. You know, there's nothing inherent in a single payer model or a multiple payer universal model that would either make, you know, better quality and greater equity more or less likely.
Peter?
Yeah, well, I agree with that, except I think that the option A really has the most potential for doing this well. You know, if you looked at, first of all, on the fill in the gaps, it's pretty much left up to market forces and what people decide to do. It's sort of the same for delegated administration, even when you have guidelines for this. And quality and equity, of course, is going to be an essential part of this. And this is not just did you do the right stuff, but really analyzing, sort of patient-centered outcomes in terms of did the patient actually do better because of the things that you did. So I would say that understanding that it depends how it's done. I think option A has the best potential to do this well.
Looks like
Rod.
Rod has his hand up.
Yeah, there are no quality improvement programs that we are currently involved in that have any effect on quality. I think Medicare's programs and the state programs has absolutely nothing to do with what is the ultimate outcomes in the patients. What we need to do is be gathering real data that's not claims data in order to measure quality and outcomes. We're not doing that now. I don't see how a different system would do that. I would hope that's something that we do in the future, and that's a goal, but I don't see how option A, B, or C would be any different.
And Kirsten, it looks like her hand is up, but I don't see her. Oh, there she is.
No, I just want to second that too. I think this is one of the hardest ones to pinpoint, and it's going to be very much driven by incentives and what goal setting out is out there. You're going to have to, you're really going to need provider buy-in into this, and where are they going to get the resources to do all this on top of providing care? It's quality assurance and.
Thank you. That's really great feedback. Okay, so let's move to administration and feasibility, thinking that you guys will have some opinions here.
There's quite a bit here. I can't put it all on one screen. Well, so.
Aaron, do you want to go ahead?
Yeah, consistent with, comments I made earlier in the meeting. I mean, I think I know that Rod disagrees with this, but I think the evidence is pretty strong that administrative costs in a single payer system, I'm not talking about any government system, but in a single payer system is lower. That doesn't mean all administrative complexity is either better or worse, but I'm just saying that overall, I think that's what the evidence shows. And I've always, in my, study of, health system design, to me, it's having a single point of accountability in a singular system, and it could be a multi-payer unified system, is a precursor to some of the rest of these bullets. So a precursor to really being able to reduce duplication of service, a precursor to being able to really control health services, et cetera. So, and value-based payment. I mean, I'm a cynic about value-based payment as a mechanism, but if we came up with a mechanism that actually promoted, sort of hearing Rod's point, actually promoted real quality, it would be much easier to disseminate throughout the healthcare system in a unified system, as opposed to the chaos that we live in now.
Rod?
I'm going to disagree with Aaron a bit in that I think if what we're talking about is a system that is like Noridian, Medicare Part A and B and C, then you have the most cost-effective system that's in the entire country. If you talk about the Medicaid Healthy Options system, you probably have the least cost-effective, most administrative, wasteful system that there is. But, we do have an option of looking at something like the state employee benefit plan. If the state were to underwrite the cost and it's based on that, then you have an extremely lean, efficient system that every physician and hospital in the state would love to have. And then once you get everybody into one program, then we can start working on making it even better and moving toward a value-based payment. But, I think it's just, saying it's government versus not, more efficient, they're not. You have to get into what are you actually talking about. And the Medicare system is extremely efficient. I totally agree with that.
This is Janine. So, Dr. Trico, do you think then that if you did move to a universal coverage, you could mimic that you admire in Medicare, or not?
Oh, absolutely. But it's not what we do. I mean, if you look at the closest thing we have in the state to a single payer system is Medicaid. It's extremely wasteful. So it depends how you do it. I mean, the state runs a very large program called the State Employee Benefits Plan. I mean, it's a model, I think, of efficiency. And if you got rid of the underwriting costs that's associated with health plans underwriting, which is 10 to 15%, suddenly you have an extremely lean delivery system that would be well accepted by the entire population. I wish I could get a Regents Blue Card as a retired state employee, but I can't. If I could buy one, or you could tell me how to do it, I would love to hear it.
I'll sell you mine.
So it sounds like this area is one in which, kind of, Aaron, back to your opening comments for our larger meeting, what is the evidence telling us? What is where are there examples out in the world that we could use to draw from and to build this system? Is this a place where we would dig into a lit review, get research? Because I'm hearing some themes, and this is what we were kind of anticipating. I'm just testing my thinking here. For quality and equity, for example, you all said it depends a lot on policy and implementation. It depends on some, incentives and provider buy-in and resources. Not that there isn't data about how to do that, but it's more of an implementation question. And here it's more of a, you're going to choose something and you need to be informed about what's working out there. So is that a place that we could go for the next meeting, for example, and dig deeper?
Yeah, I would say very much so.
Okay.
To give you an example, about 15 years ago or so, and I think this may be an article that I sent Jamie and maybe not, but there was a study, so in Germany. So Germany has basically a universal multi-payer system. And this was relatively early on in the care management, sort of the development of care management initiatives. And they did some work to study what kind of care management would actually improve the care and be more efficient. And there was a study looking at what happened in Germany. And in Germany, because they have a unified system, even though they have multiple payers, they were able to implement the quote best practices care management system entirely throughout their whole system, because it's a heavily regulated multi-payer system. So that kind of evidence suggests to me, it's just one piece of the evidence to suggest that a unified system, models A or B, facilitate. If we can figure out best practices, those models will facilitate the dissemination of best practices throughout the system. And yes, so research, evidence can be brought to bear on that point.
That's great. Thank you. Yeah, that's what we're looking for. Dr. Tricco.
And it is being done in this country, in Maryland. I mean, Maryland has a very similar system in all payers, bringing in physicians. But I just have a hard time understanding how we're going to change the entire system of paying physicians. It's a very difficult thing to do. What Maryland is doing is moving toward global budgets. That may be an easier goal for us to do on a state level rather than try to rearrange the entire way that we pay physicians in hospitals. We get them into a single system, they're entirely regulated, and then we develop a global budget, and then we work together to cut costs, and that's the way that we eventually are going to get the waivers that we need from the feds.
So I want to make sure, I know, Mia, we don't have a ton of time. I want to make sure we get to the last two criteria. And if you guys would think, as we're going through the last two, again, about where do we need to dig deeper for evidence and best practice, so that, you know, we can do the necessary lit review.
Actually, I think this is the last. I think the admin feasibility is just long, has a lot of
That was it,
bullets.
Janine? I thought we had 6. So good. All right. So I'm off. I guess
So
we're on
there's
track.
more for the feasibility of impacts on.
Got it.
There's more detail, just administrative cost reductions and best
So
practice.
if we were to look at, then if we were to go back to the top, we've got access, governance, and I think we talked a little bit about quality and equity. Is there any place where we should be digging to bring the data forward to help inform the build versus, or, you know, the structure of what we want to end up with versus an implementation question, a policy issue?
Aaron?
Well, I'm not sure if this is what you're asking, Betsy, but it would be useful to look at a range of existing systems, both internationally, but also, you know, I think Rod's point's a good one, looking at, you know, Medicare, Medicaid, state employees, and not just our own. You know, almost every state has some sort of state employee plan, to see how they deal with some of these issues under access, for example, experimental treatments, or you know, elevating preventive and primary care, workforce capacity, which we haven't talked about, which is obviously kind of important. So that kind of real world information, you know, how does this actually working in different systems, would be helpful.
Okay, so to the extent that evidence exists under the these issues for the various criteria, what are other systems doing?
Yes.
So we can pull apart. And Janine, I think that's probably not, I mean, you know, we have a good sense of, yeah, there's evidence to suggest that these issues under access are being dealt with, and here are the ways that they may be dealt with in these various systems.
And maybe, you know, they would point to, you know, again, Rod's, you know, I think important observations. They would point us towards, well, this model, in his case, the Public Employees Benefits Board, that's what we want to shoot for, not this model, Medicaid. I'm not sure I agree with them, but in any case, what the information that would help us understand, you know, this is the direction we want to go. These are the policies that would set this thing up in the right direction.
Mm-hmm.
But you're not talking about necessarily the structure. It's still universal coverage, state administered, but you're saying the implementation should be maybe more along the lines of PEB.
Right.
You know,
So you know, if we took Rod's you know, observations, it would be Model A should, or even Model B should be structured using, let's start with PEBB since it's homegrown, and let's build off of that. So that would be a nice, you know, if we could get to that point based on our review of, you know, various models.
And
I mean, various real systems.
I think they're going to pull us out in just a minute.
That was great though. This is a nice conversation. And then we could apply, looking at those various models. So keeping with our PEBB example, how well does PEBB do under these various qualitative assessment criteria? How do they address, and is it sufficient? And then kind of mix and matching with other systems potentially to say, here's, you know, access is really well addressed in this other system in this way.
Yep.
Okay. Thank you for the good
yeah,
feedback.
I mean, it'll be though, to see if there are studies though that can really answer all those questions. Just to caution, I mean, we can look at how maybe the mechanics of them are, but I don't know how much detailed studies there are at that sort of higher system level. So it'll be.
And I think, Janine, that'll be the question for us, is where
Yeah.
is and where there isn't, and just being clear about that.